Good afternoon, everybody. Welcome to this non-promotional virtual masterclass webinar, organised and funded by AstraZeneca and MSD. And today we're going to be sharing the lessons we've learned from the 2021 EQA scheme for molecular testing of BRCA and other HRR gene variants in ovarian and prostate cancer. Next slide, please. So just a couple of slides before we get going. Really just want to remind you of the housekeeping rules. Your microphone has been automatically muted, so we'd obviously like to avoid any background noise whilst we're presenting the information to you. Just to note, the webinar is also being recorded and will be shared with you or with the participants, and for accessing, if you like, outside of the webinar, via the GenQA, EMQN and other associated relevant websites. So it takes about a month for that to come through, but we will let all our participants know when that's available. And finally, this is probably the most important, this is an interactive session, so we do want your contribution to it. So you can use the question and answer function through Zoom to submit your questions during for the discussion at the end of the session, the dedicated Q&A session at the end of the webinar. And obviously we are limited to 60 minutes today, so if we don't get through all of your questions, then we will of course come back with our responses to any questions we haven't answered after the webinar's taken place. Next slide, please. So feedback is an important part of this process for us. We obviously have to learn from it as well. Do contribute your feedback to us. You will receive an email after the masterclass with a short link to a feedback survey. It shouldn't take more than 2 or 3 minutes for you to complete, but we do strongly encourage you to submit your feedback so we can improve as well as we go through. So please do contribute to the feedback session. Okay, next slide, please. Right, so we've got this is the 6th time that Sandi and myself have done our double act. We love doing it. We love feeding back to you guys about what we've been doing over the years. It comes as no shock then to know that it's both myself, Simon Patton, I'm the CEO of EMQN, and Prof. Sandi Deans, who's the Director of GenQA. And we'll be giving you the usual potted history of what's been going on last year. So we're looking forward to sort of overviewing and feeding back to you on the 2021 EQA schemes. Next slide, please. So this is our disclaimer. Next slide, please. So let's start with the usual reminder, because obviously every year we have about 1/3 of laboratories who've never participated in the EQA before. So a quick overview, just a couple of slides as to what we're doing and why we're doing it. So this series of EQAs is a collaboration between EMQN and GenQA. We're running 3 EQAs, and I'm sure you're all familiar with them. It's the 6th time we've run an EQA for germline and/or somatic BRCA testing in ovarian cancer. And this year is also the 2nd year we've provided an EQA scheme for somatic testing of HRR genes in prostate cancer. It couldn't happen without the support from AstraZeneca and MSD, so we gratefully acknowledge that. That does allow as many laboratories to participate as possible. It's fantastic. And the format is the same for all those 3 EQA schemes, that we provide you, the participants, with 3 EQA samples per distribution, so per EQA scheme itself, matched with a corresponding clinical case. And you are really essentially asked to test those samples according to the clinical case referrals. Like all EQA schemes, you are really supposed to be assessing routine practice. So we would expect you not to do anything particularly special for the EQA, but to test the samples as you would do your routine protocols, normal staff, etc., etc. So you try and replicate your normal laboratory processes again. And if you like, an EQA is effectively an examination process of your test processes. And behind the scenes, there's a very big group of volunteers who help us make this activity work. So our assessment team across all 3 schemes is composed of 42 different volunteers or assessors from 16 different countries. We gratefully acknowledge their contribution to this as well, because it's without them these things don't happen, and they have provided their expertise to us to make it work for you guys. And to make sure that we're consistent across all the EQA schemes, we use a harmonized marking criteria set to ensure there's consistency between all the different EQA schemes, and that the marking is applicable year on year for consistency. Next slide, please. So again, a brief overview. So the main principles of all EQA schemes is that everybody's provided with the same material for testing. That's obviously very crucial if you want to be able to draw conclusions about analytical performance. You return your results to us for assessment. We do ask you to treat those samples as a normal patient sample. So as I said before, routine procedures, staff, etc. And then we determine the accuracy of your results and benchmark you against your peers and against the population of all the laboratories taking part in the EQA. And of course, obviously that's very advantageous for a number of different reasons. It gives you a very good benchmark figure of the quality of your service. We put a lot of effort and time into structuring these EQA schemes so that they provide some educational component to it, so you learn from them as well. And clearly things like this webinar also contributes to the training process. So education and training are really key to our delivery of our EQA schemes and something we take a lot of time into and pride over what we're trying to do. And finally, though, we can't underestimate that there's also a regulatory component to any EQA scheme. And obviously it forms part of the accreditation process, and regulators, commissioners of services, and other service users of your laboratories take note of what you are doing in your EQA performance. In some countries, there can be significant consequences to that if there's a consistent poor performance from a laboratory. So there is a regulation component, but the key thing I think for most of the EQA schemes that EMQN and GenQA organise is really around the education and training that comes from taking part in these activities. Okay, next slide, please. So Sandi and I are going to take each scheme one at a time. So I'll be talking about this scheme, which is the germline testing for BRCA and HRR gene variants in ovarian, breast, prostate, and pancreatic cancers. And then Sandi will do the somatic testing of ovarian cancer, and I'll follow up with prostate. Okay, next slide, please. So just looking at the data, so we've changed slightly how we just demonstrate the information for you now. So we've given you a breakdown of the number of laboratories registering each year, and a split between those that are new to the EQA and those that are existing or participated before. And you can see that this year there was a limit on the number, a quota on the number of laboratories set at 300, and about a third of those laboratories that participated this year are new to this EQA, have never participated before. Slightly lower than last year, but encouraging nevertheless. But we would obviously like to see more laboratories routinely participating. And when you look into a breakdown of the, if you like, the regional participation data, you can see that about 40% of the laboratories come from Europe. Another 28% of laboratories come from the wider Asia Pacific region. 25% of laboratories come from China directly, and the rest is made up of laboratories in other global regions, including Africa, the Middle East, North and South America, and Oceania. Next slide, please. So for this EQA, we distributed 3 genomic DNA samples, and these were extracted from lymphoblastoid cell lines that EMQN has in Manchester, in our location in Manchester. We selected them for specific variants and obviously with known results to ensure we could provide a fair challenge to the laboratories. And all the samples were independently validated by next generation sequencing in 2 different laboratories, including CMV analysis prior to the distribution to laboratories. So one of those validation laboratories used in the Illumina NextSeq 500 this year, using a panel of 115 different cancer genes. And then confirmatory Sanger sequencing for any pathogenic variants detected, whilst the other laboratory again used another Illumina platform, but this time a MySeq rather than NextSeq, a smaller number of genes, so 38 genes, using a custom panel from a commercial provider. And again, this laboratory also performed CMV analysis using the same NGS platform, and any additional data was checked using orthogonal approach via Sanger sequencing. Next slide, please. So case one was a female, Rasha, who'd been diagnosed with high-grade serous ovarian cancer, which was platinum sensitive, and testing had been requested to determine treatment options. And the rationale for including this case scenario was maintenance therapy after the response to a first-line treatment with platinum. And the question really was, has the patient, i.e. they have not relapsed, should I say, and the question was, is a pathogenic variant present in this germline sample? Next slide, please. So in this sample, there were no pathogenic variants present in either BRCA1 or 2, but we included a pathogenic variant present in CHEK2. So a homozygous variant, C1263del, leading to a predicted frame shift and termination, early truncation of the protein. There were 2, or just under 1% numbers of critical genotyping errors this year in this case. Both were false positive results. So one laboratory reported a exon 6 and exon 13 BRCA1 deletion, whilst another laboratory reported multiple copy number variants in BRCA1 and BRCA2 that weren't identified by any other laboratory and weren't detected in the validation prior to testing, prior to sample distribution for other laboratories. Looking at the data, and I think this is it's important to highlight this, that both these laboratories, the laboratories that made the false positive, or got the false positive results, the critical genotyping errors, both used NGS approaches for CMV analysis. And this highlights, I guess, a common problem we see with this approach at the moment, is that the bioinformatics pipelines really do need to be very thoroughly validated for CMV analysis, and or at least another orthogonal method used, such as MLPA, to confirm CMVs detected by NGS. So this is not the first time, obviously, we've seen it, but it's as laboratories implement direct CMV analyses using NGS, it's certainly an area where we are perhaps not concerned, but keeping a close eye on laboratory practice. Next slide, please. Of the laboratories that actually tested the sample, 34 or just over 30, just under 13% actually tested for CHEK2. So not a huge number of laboratories actually testing CHEK2. 6 of those laboratories failed to report the zygosity of this variant, or reported it incorrectly. So they reported it, instead of being homozygous, reported it as being heterozygous. And also interesting, I suppose, in this context is that, unsurprisingly, quite a lot of laboratories using panel testing, but quite a few laboratories, whilst they said they tested for the CHEK2 gene, only reported the results for BRCA1 and 2, which, given the fact that there is good evidence to show a relevant effect of this variant in CHEK2, was a surprise to the assessors. So next slide, please. So good to hear that there was no critical interpretation errors this year in this case. That's great. And 50 laboratories, or just under 20% of laboratories, failed to mention the response to PARP inhibitors. And this is a common theme we've seen in this scheme over the 6 years that we've been running it. I guess it's surprising still to see that it's popping up. And the interpretation of the CHEK2 variant was variable. So possibly because there's less information in the databases about the implications of a pathogenic CHEK2 variant in the context of ovarian cancer itself. And that's possibly very true. But the assessors did expect for the laboratories to say something about the significance of finding a CHEK2 variant in there. And as a minimum, we would expect laboratories to mention referral for genetic counselling and to discuss the implications of the result. So 13 out of those laboratories that undertook CHEK2 testing, so 38% of those labs that did CHEK2 testing, didn't report the need for, or advise, should I say, for genetic counselling or follow-up in this patient itself. Next slide, please. So case 2, the scenario used for case 2 was a patient called Francesca Toshi, born in 1969. And Francesca had been diagnosed with metastatic pancreatic cancer, which has been shown to be platinum sensitive, and she was being considered for PARP maintenance therapy. So again, the rationale, this is the same as the first case. So maintenance therapy after response to first-line treatment. And the question was, is there a pathogenic variant present in the germline? Next slide, please. So in this case, the expected result was we were expecting the laboratory to detect a heterozygous deletion of exons 1 to 3 in BRCA1, including the upstream promoter region, and no pathogenic variant detected in BRCA2. Very high critical error rate in this genotyping error rate in this case. So 27 laboratories, or just over 10% of laboratories, made a critical genotyping error. 9 of those 27 were due to a false negative result. So the laboratory simply failed to detect the deletion, despite the fact that the test scope that they defined on their test report said they could have detected it. So all those laboratories received a critical genotyping error. And the remainder of the errors were associated with how the laboratory reports the scope of the test they're undertaking and its impact on the clinical result, the analytical result they detected. So 15 laboratories failed to clearly describe whether copy number variants were detected by the method they used for their test on their report. And a further 3 laboratories didn't report the extent of the deletion correctly. So this was assessed in relation to what the scope that they defined on the test report. So again, these laboratories would have received a critical genotyping error as a consequence of that. 59 laboratories, so another 22.4% of laboratories also didn't detect the deletion, but in this case, none of them were penalized because the results were correct within the limitations of the test that they defined on their clinical report. So they clearly stated the limitations of what they can do, and as a consequence, they weren't penalized for it. Next slide, please. A further 18 laboratories, or just under 7%, failed to state that the deletion was heterozygous. And these laboratories did receive a small deduction of half a mark for failure to state the zygosity of the variant detected. There was also significant variability in the nomenclature used to report this deletion. And many laboratories didn't report that the deletion also extended upstream. We do appreciate and understand the difficulty of using the nomenclature to actually report the copy number variants. It's not trivial. We do realize that's the case. And the HTVS guidelines, so the latest version is 20.05, do provide some guidance for how a laboratory should report copy number variants. The latest guidance really refers that laboratories, these variants should, should be reported in the extending upstream or downstream region of the transcribed region. So they should be described using genomic coordinates and not using cDNA numbering. We did take this into account, obviously, into the assessment process, but as stated earlier, we also appreciate that it's not easy to do. But as we move into the genomics era, we've got to become more consistent with the way we actually describe these copy number variants, particularly if laboratories are starting to do testing using NGS. Next slide, please. Looking at the interpretation of this case, again, like case 1, there were no critical interpretation errors, which is fantastic to see. Our assessment team did classify the deletion in this case as pathogenic using the ACMG guidelines. And there was no deduction for laboratories if they stated that the variant was likely pathogenic. So the criterion used by the assessors were PVS1, very strong, for loss of a BRCA1 allele, PM2 supporting for historical cases to support the absence of a common benign variant, and PS4 moderate with 2 different references to reports where there is clearly a family with the same, a single BRCA1 exon 1 to 3 deletion in it, or the results from further studies where, in this case, 11 families from different ethnic groups also had a BRCA1 exon 1 to 3 deletion. 9 laboratories failed to provide any classification of the deletion in case 2. And many of the laboratories are still not testing CMVs, and this case was included this year because we understand the complexities around CMV analysis. But in the context of germline testing, it is pretty well established that laboratories should be doing COV analysis. They do account for at least 15% of all inherited BRCA1 and BRCA2 variants. So there's a very strong case for any laboratory doing it to include CMV analysis. And MLPA is a pretty straightforward technology for doing it now, and many laboratories use that, but CMV analysis is really essential in this context. Next slide, please. So the final case for this year's germline scheme was a male patient, Anders Johansson, born in 1969. Anders had been diagnosed with metastatic castration-resistant prostate cancer. He'd previously been treated with hormone therapy, but was now progressing, and testing was requested to determine the eligibility of treatment with PARP inhibitors. So the rationale for this case, first-line hormonal therapy and subsequent progression. And again, the question we're asking is there a pathogenic variant present in his germline DNA? Next slide, please. So for this case, case 3, the sample had no pathogenic variant in BRCA1, but there was a heterozygous variant, a small deletion, leading to a frame shift and a premature termination of the protein in BRCA2. Slightly lower genotyping error rate, but nevertheless, there were 5 or just under 2% critical genotyping errors in this case. One of those was attributed to a false negative result, so the laboratory didn't detect the variant of interest. 3 of those were due to false positive results. So one laboratory reported an exon, a CMV, so a deletion of exon 18 of BRCA1. One laboratory reported a insertion of a single nucleotide, and another laboratory reported another variant that was a deletion of a nucleotide. And finally, there was a reporting error. So the laboratory did detect the correct variant and reported it correctly in one part of the report, but incorrectly in another part of the report. And the assessors felt that that was a significant enough error to warrant the justification of a critical genotyping error. The nucleotide position, so this was incorrectly reported for the deletion by some laboratories, and any laboratory that got the nucleotide positions wrong received a major HGVS error, so deduction of half a mark from their assessment, from their marking. Okay, next slide, please. So again, no critical interpretation errors in this case. Fantastic, all 3 cases, no critical interpretation errors. 55 laboratories, or just over 20% of laboratories, failed to state that the patient was at further risk of disease or to recommend monitoring as a consequence. Next slide, please. So looking at the scoring for this case, this scheme, not unexpected, I think you can see that case 1, which was least controversial in terms of clinical scenario, had the highest scores for genotyping and interpretation. For genotyping, and case 2, which is the CMV analysis case, clearly had a much lower genotyping score. Looking at interpretation and clerical accuracy is generally pretty good across all reports. So that means the standard of reports in terms of conveying information and how it's written down is pretty good. But interpretation is always a bit more subjective, and you can see there's a bit of variation between all 3 cases. Next slide, please. So looking at the performance trends, so here you can see the data for the 6 years that we provided the scheme, and we've presented the data slightly differently this year. So you can see the numbers of labs that participated in terms of submitting results, and those that withdrew and those that didn't submit results. So about 5% of laboratories this year withdrew from the scheme. In other words, they let EMQN or GenQA know in advance they weren't able to submit results or weren't going to be able to finalize their participation. But another 5 laboratories didn't submit any results at all and didn't tell us why they weren't doing so. And I would put a strong plea out for those laboratories that you really do need to let us know in advance why you're not submitting results, or at least provide something in your results submission. Those 5% laboratories depriving other laboratories of a participation in the scheme, and we would like to see those laboratories at least telling us why they're not submitting results. Other laboratories would love to have participated, and we could have filled the scheme So please, if you are one of those laboratories, do in future years tell us why you're not submitting results, so we understand the reasons and justification for you not submitting results. Those laboratories that don't submit results and don't tell us why do receive poor performance on the basis of non-participation. So there's a justification for you letting us know in advance. Looking at the assessment scores, you can see that the genotyping scores are generally the mean genotyping score across all the years is pretty consistent nowadays, at least above 1.8. But and likewise, the interpretation scores are lower. But again, it's hard to say there's a trend of improvement there. It's variable, and it's much more variable because of the clinical context we provide every year. Interpretation is just a bit more difficult to assess as well. But you can see when we look at critical error rates, so these are errors, as I said before, that could lead to potential patient harm or potential patient harm. You can see that the critical error rate has dropped drastically since we first started running our first non-pilot scheme in 2017, and we're now down to less than 5%. Obviously, last year was a slightly different clinical scenario, so the error rate was down to 2%. But this year, 2021, is the first time since 2017 that we included a significant copy number variant in there. And you can see in 2017, over 10% of laboratories made an error in the CMV analysis. So the error rate, the mean error rate has come down. That's great to see. And that's also reflected in the assessment scores above in the graph above. But looking at poor performing laboratories, about 11% of laboratories this year were poor performers. And most of those were poor performance based on getting one genotype wrong. But there were about 1% of laboratories got at least 2 of the 3 cases wrong. And we would obviously clearly like to see that error, that poor performance level come down over time. Okay, next slide, please. So I think this is over to you, Sandi.
Thank you very much, Simon. Okay, just like to thank everyone for joining and add my welcome to Simon. So I'm now going to talk about the second EQA that we provided during 2021, and that was on the somatic BRCA testing in the setting of ovarian cancer. So next slide, please. So here we have broken down the demographics of the participant labs in the same way as we have for the germline scheme, and you can see here that we didn't have the 300 limit for participations in the somatic scheme, and therefore we had a higher number of participants. However, you see here that we do have existing participants from previous years actually dropping out and not participating annually, and we would definitely recommend that annual participation does happen. It's very important to make sure that you are reassured of the quality of your testing at least once a year. But the good news is we're also seeing a steady stream of new participants in this EQA. Again, we can break down the geographical location of the participating laboratories. Here we have more labs based in the Europe region who are participating in the somatic scheme compared to germline, and there's also a slightly smaller number of those within the Asia Pacific region. However, we do have a wide global spread, and I think that's the most important thing here, that EQA is being recognised globally to be incredibly important in this field. So next slide, please. The challenges are slightly more difficult for delivering an EQA in the somatic field of testing. We have issues with obtaining samples. We really, one of the remits of an EQA provider is to provide samples for testing that really mimic as closely as possible to the real clinical cases and samples that come in the door to the laboratory for testing. However, we know that we cannot get enough tissue samples that will cover the huge number of participants in these schemes, so we do have to look at some way of manufacturing artificial material. However, it would be easy to send out somatic fragmented DNA. However, we do truly believe that EQA is about the end-to-end assessment process, and therefore we do want laboratories to be able to extract DNA from some sort of tissue sample. So we provide FF8PE material because extraction is part of the process, and we do want to assess that. We have many labs at times who request extra samples, and we know that that is a valid reason for asking for repeat samples from the EQA provider. provide us. However, we do track failure results because this is something that is part of the assessment. And if a laboratory is continuing to fail to be able to obtain testable DNA, then actually that's part of an issue, and we can help in resolve those issues with the laboratory. We also have a range of different types of laboratories performing this somatic testing. They can be within the pathology arena, cellular pathology departments, or within the genomic testing laboratory infrastructure. So we really need to make sure the somatic scheme is fit for purpose despite where the laboratory may sit, because they're still providing patients with these results. Also, there's different national approaches to testing strategies. We have the tumour first or germline first, and that can be either a local or a national policy. And therefore, we would like to incorporate all different elements of that, hence the somatic scheme and the germline scheme being split into two. And we expect both BRCA1 and BRCA2 to be tested and reported by all laboratories. We also see variable experience interpreting the variants when they're detected, and be able to make sure that we assess the whole remit of those testing results coming through. We provide a range of the types of variants and different classifications. So again, we can give the labs reassurance that they have the expertise to be able to identify and correctly classify the pathogenicity of these variants. To make sure that we know what the right result or the expected consensus result is, we have an expert review of the classification evidence to make sure that we can feed that back to the participating laboratories, and that again comes in the educational element of the EQAs that Simon was talking about. One of the other issues, particularly for somatic testing in this area, is about understanding the importance of the potential of germline variants. It's not clear from the assays being performed to determine whether or not the variants detected are somatic or germline, and really we need to be reassured that the labs are aware of this and report the results in the context that there may be a potential germline variant present. So we do include this in the marking criteria, and we've discussed many times, and this year in particular, in the EQA summary report that's issued, and also on today's webinar. So next slide, please. So the samples that we do provide, as I mentioned, are artificial FFPE samples manufactured through a commercial company using the EMQN cell lines held in Manchester. They're selected for specific variants, and we do know the results. So we're hoping to challenge the laboratories with both easy cases, but also those that maybe are not come across in such high frequency through normal clinical testing. And then post-sectioning, just to ensure ourselves that we know what the expected results and the samples are able to give reportable results. All samples are independently validated. And this time they were using, both labs were using NGS prior to distribution. So here you can see one laboratory validated using a custom QIAseq QIAGEN panel on an Illumina platform, and the second lab used NGS platform on the Illumina NextSeq after enrichment strategy testing. So next slide, please. So we've got 3 EQA cases for the somatic scheme. The first is a lady who has had surgery, and she has confirmed to have serous ovarian cancer. She's shown response to platinum-based therapy, and now testing has been requested to determine further treatment options. So a very mainstream normal referral coming into the laboratory for testing. So the question is, would maintenance therapy after response to first-line treatment with platinum, not relapsed, is the question, and is a pathogenic variant present in BRCA1, BRCA2? So next slide, please. The validated and expected results for this case was it would be classed as a wild type, as we used to call them, so no pathogenic variant detected in BRCA1 or BRCA2. So there were 4 critical genotyping errors reported for this EQA, which contributes to 1% of participating laboratories, all for 4 different reasons. However, all were false positive results reported. So one laboratory incorrectly reported of a different BRCA1 and a BRCA2 SNVs in the same sample. One laboratory incorrectly reported the presence of a copy loss of exon 18 in BRCA1. 1 reported the presence of 3 VUSs in BRCA1, and the 4th laboratory incorrectly reported the presence of a BRCA2 variant. Next slide, please. However, there were no critical interpretation errors, so the results that were reported with no pathogenic variants detected were reported appropriately. However, there were deductions given, and the main reasons for this were not providing any indication about potential responses to PARP inhibitors. So very, very similar to those interpretation errors that we noted in the germline scheme. Also, which is an issue which is related to specifically for tumour somatic testing, is there were several labs who did not provide any indication of the neoplastic cell content of the tumour. So in a case where no pathogenic variant is detected in particular, it's especially important to provide this information, and therefore the labs did receive deductions. And the reason for this is there is a possibility that a tumour sample has been tested but did not actually contain a high tumour content or any tumour content at all, and only normal tissue was tested. Therefore, it's important that when no mutation or pathogenic variant is detected, that this limitation is stated, or the fact that tumour content was detected, and thereby the interpretation of the result is more adequate in the presence of tumour where nothing has been detected. So next slide, please. So case 2, very, very similar rationale and clinical scenario. Another lady who is looking for a pathogenic variant present in BRCA1, BRCA2 for maintenance therapy with PARP inhibitors. So next slide, please. This time we did have a pathogenic variant detected in BRCA1, which was a single nucleotide variant in the splice site region with unknown protein impact to determined. We had a much higher genotyping critical error rate in this case compared to case 1, with 21 different critical genotyping errors reported, which equates to 7% of the participants. We had 10 laboratories reporting false negative results, so they did not report the BRCA1 variant present in the sample. We also had multiple laboratories reporting incorrect variants, and that ranged from BRCA1 and BRCA2 variants right across the gene, and also includes deletions of multiple exons in a wide range. But we also had 3 laboratories who incorrectly reported the variant in BRCA1 as well. So we also had 2 laboratories who unfortunately looks like had swapped the samples or the data for the EQAs between this case and this case 3, and switched the results for submission. So these were reported in the case of case 2 scenario for patient, and therefore were deemed a poor performer. Next slide, please. We also, this is a known splice site variant detected in breast and ovarian cancer patients, and it's suggested that it's a pathogenic founder variant in the Norwegian population, and we quoted the references here for the participants to be able to follow that up if it's something that they had not evidenced in their submissions. Also, functional studies have confirmed that the sequence change results in skipping of exon 18 and loss of function of the BRCA protein. So it's very clearly a pathogenic variant. So because it's a splice site variant and the protein change is unknown, it should be reported as P. question mark. And this is in line with the current HGVS nomenclature guidelines. Now, if the laboratories did not give indication of the protein change in this way, it was expected that they would include a biological interpretation of the variant. This was very variable. Different laboratories dealt with it in different ways. And because it was a new sort of field and issue, that we decided not to apply any deductions for this, but comments were fed back to participating laboratories. Next slide, please. Interpretation, unfortunately, we did have 1 critical interpretation error, but as you can see here, the overall percentage of labs, this is really very, very small. This laboratory reported the variant as a VUS, so a class 3, and stated that it probably affects splicing without any pathogenic effect. reported in the database variant that they classed as pathogenic instead of benign. Also, the main deductions from interpretation scores in this case were for not referring patient to clinical genetics. And as I'd mentioned previously a few slides ago, it's very important to be aware that the potential for this variant to be germline, and really the report should state or at least flag that this is something that should be considered. Also, some laboratories interpreted the variant as being germline in origin due to the variant allelic frequency reported, which was high. Again, this is misinterpreting the result, as these assays are not validated or not able to give you accurate variant allelic frequencies, and therefore you should not overinterpret whether it's a somatic variant or a germline variant. So next slide, please. The final case for this EQA, again, was another lady who had serious ovarian cancer. And again, she was tested to determine further future clinical management. So again, it's the same scenario as cases 1 and 2, which is very mainstream and would be expected to be tested in each laboratory. So next slide, please. This case had a pathogenic variant detected in BRCA1 and no pathogenic variants detected in BRCA2. We had 14 critical genotyping errors, which is 5%. The majority of these were false negatives, again, as we saw in case 2, whereby the laboratories failed to report the presence of the pathogenic variant. We also had another 6 laboratories, 5 laboratories, can't count today, incorrect variant reported. So some incorrectly detected a BRCA2 variant, 1 incorrectly reported a BRCA1, copy loss of exon 8 and 21, and a copy gain of exon 16, and BRCA2 copy loss of exon 6. So a huge smattering of incorrect copy number variants detected by that laboratory. And then we had another laboratory, 3 laboratories who incorrectly reported the variant in BRCA1. As mentioned previously, for case 2, we had other laboratories who indicate to have had a sample swap internally at some point in their testing process. Interpretation, again, we had 1 severe critical interpretation error, which overall is a very low percentage of laboratories. And the main reason for deduction in this case is really the same issue as in case 2, and that was failure to refer the individual to clinical genetics or for genetic counselling. So next slide, please. This is a summary of the scoring applied across the 3 categories: genotyping, interpretation, and clerical accuracy. You can see that here that the genotyping accuracy was much higher for case 1, so that is the case with no pathogenic variants detected. However, the interpretation scoring, mean scoring, was much lower than the other cases. For case 2 and 3, you can see it's very, very similar, and these are the laboratories who either failed to detect the pathogenic variant present or detected an inappropriate or incorrect variant and reported as such. And as Simon mentioned, with the germline scheme, our clerical accuracy is really very good, and the patient identifiers and all corresponding information on the reports were pretty well covered and included. So next slide, please. Again, we can look at the performance trends. You can see here that the overall poor performance really has decreased compared to the germline percentage. We see here that in case of the genotyping and interpretation, the overall scoring really is quite settled. It is relatively high, although we do still see those critical errors coming through. And the middle graph here on the right hand side, you can see that these really do usually sit within the genotyping category. So this really would result, if you extrapolate it to clinical service, the patient receiving the incorrect result. And really this is why we encourage laboratories to continually participate annually. The interpretation scoring tends to fluctuate, and again that depends on the challenging case and the scenario that we supply for the EQA. And as I mentioned here on the bottom graph, the number of poor performing laboratories is a lower percentage than those seen in the germline. However, we see a much larger number of laboratories who report more than one critical genotyping error, and that is either 2 and in some cases up to the 3 EQA cases are all incorrect. And again, really that just demonstrates the continual need for EQA in this field. So next slide, please. I'm now going to hand back to Simon, who's going to talk about the third EQA, which is the second somatic EQA scheme provided in this arena this year. Simon, now back to you.
Thank you very much indeed, Sandi. So, yep, it brings me to wrap up the overview of these schemes with the somatic HRR testing scheme for prostate cancer. So next slide, please. So this is the second year we've run the scheme, and as a consequence of that, obviously there weren't a huge number of laboratories carried over from last year, but about two-thirds of laboratories who participated in the original pilot also participated this year. But the majority of laboratories, up to our limit of 100 laboratories, were new laboratories to the scheme. And again, very similar, I think, to the somatic ovarian cancer scheme. You can see again, just under half our laboratories come from Europe, and then another 40-odd% come from the Asia Pacific region more widely, and/or China, and then made up with countries from around the rest of the countries around the world. But again, as Sandi said, it's great to see this is a truly global EQA scheme, and the representation from laboratories globally is fantastic. Next slide, please. So in this scheme, we again use 3 artificial FFP materials, just like we did for the somatic ovarian cancer scheme, using EMQN cell lines, manufactured and embedded for us by Horizon Discovery Limited. We selected variants in 4 different genes for use in the scheme, but during the planning process, obviously the licensing requirements for metastatic castration-resistant prostate cancer changed. So an indication of BRCA1 and 2 only, and therefore we only assess the results from these genes. Post-sectioning, like all the other schemes, the samples were independently validated using NGS by, in this case, three different laboratories prior to distribution. I appear to have missed one out though in the table, so apologies for that. But the first laboratory used a custom QIAseq panel from QIAGEN on an Illumina platform, and the second laboratory used another QIAGEN panel on an Illumina platform as well, but a different QIAGEN platform. And just something to highlight here, last year was the first scheme. It was a pilot scheme, a very limited subset of laboratories. This year was open to up to 100 laboratories, and we introduced EQA performance criteria to the scheme this year. So this is the first year of performance assessment of the laboratory results. Next slide, please. So looking at case 1, the scenario for case 1, a gentleman, Matthew Stewart, born in 1950, who has metastatic castration-resistant prostate cancer. He's been treated with hormone therapy, but has now progressed, and testing has been requested to determine eligibility for treatment with PARP inhibitors. And the rationale behind this case is progression after first-line hormone treatment, and use of PARP inhibitors have been considered. And the clinical question we're asking is a pathogenic variant present? Next slide, please. So in this case, the validated result was a 62 base pair deletion in BRCA1, predicted to lead to a frame shift and a premature termination codon, and no pathogenic variant detected in BRCA2. We selected this case because 62 base pairs is a challenging size of deletion for next generation sequencing technologies, and therefore a relevant size of deletion to include in the assessment process. So 13 laboratories, or just under 16% of the participant laboratories, failed to detect the variant or made a mistake in the process and received a critical genotyping error. 11 of those errors were due to a false negative result, so they didn't report the presence of that BRCA1 variant. And a further 2 of those laboratories reported a false positive result. So one laboratory reported an incorrect result for a different BRCA1 and a different BRCA2 variant, whilst another laboratory incorrectly reported the presence of another BRCA2 variant. So looking at those 13 laboratories, there are actually 21 laboratories who reported the sample as not having a pathogenic variant in BRCA1 and or BRCA2. So 11 of those laboratories, as we've covered before, didn't provide sufficient details of the limitations of the test they used. So it was impossible for us to determine whether deletion was within the scope of the assay they used. And all of those, as we said before, received a critical genotyping error. However, there were another 10 laboratories whose reports didn't contain sufficient information to allow us to determine, who did contain sufficient information, and therefore allowed us to determine that the assay performed wouldn't detect that deletion. So in the context of this scenario, those laboratories were considered to have used a test within the, reported the result within the limitations of the test they actually used, so therefore didn't receive a deduction. Next slide, please. It was a deliberate decision to use this case scenario, so the size of the deletion may have been larger than limits of detection from many assays used. And a common problem we saw with the reporting of this was that laboratories weren't very good at describing the limitations of their assay. So many of them provided a very, very general statement about the limitations, like the assay is unable to detect deletions or indels, shall I say, greater than 30 base pairs. Another problem we saw was that some laboratories interpreted the variant as being somatic in origin due to the VAF that was reported of less than 50%. And in all cases, if this is the case, it's obviously good practice, first of all, to refer that patient for further testing, for germline testing, because the variant allele frequency may not be accurate, and the validation data from your laboratory test process may not be as good as it should be. But in this particular context, when you're reporting a deletion, variant allele frequencies are known to be inaccurate for deletions because not all the reads are counted during the bioinformatics process, and particularly when you're doing the alignment process. So you can't take this data as being 100% accurate. Looking at the interpretation data, there was one critical interpretation error for this case. So in this case, the laboratory incorrectly stated that the BRCA1 variant reduces the likelihood of the patient obtaining clinical benefit from a PARP inhibitor, whereas of course it's the reverse, in fact, is what you're looking for. Next slide, please. So case 2 was a gentleman called Henry Smith, born in 1968, and Henry has been diagnosed with metastatic castration-resistant prostate cancer. He's been treated with hormone therapy and is now progressing. So effectively the same scenario as in case 1. And the clinical question we're asking is there a pathogenic variant present? Next case, please. Well, next slide, please. So in this case, there was no pathogenic variant detected in BRCA1, but there was a variant detected in BRCA2. And 5 laboratories, or 6% of those laboratories participating and reporting in this case, made critical genotyping errors. 3 of those were due to a false negative result, so they didn't report the presence of the BRCA2 variant. And a further 2 laboratories reported a false positive result. So one of those incorrectly reported the presence of a BRCA2 variant, a different BRCA2 variant, and the other reported the presence of another different BRCA2 variant. There were no critical interpretation errors, and the main deductions were because of insufficient details of the methodology used, assay limitations, how the variant had been classified, and/or no referral to clinical genetics. So common themes across all of all the assessment for all of these different EQA schemes. Next slide, please. So the final case for the prostate scheme was a gentleman called Sebastian Schmidt, born in 1965. Again, Sebastian's got castration-resistant prostate cancer that's metastasized to his bones. He's received taxane-based chemotherapy and hormone therapy and is now progressing. So it's been considered for PARP inhibitor therapy. So progression, the rationale is slightly different here. So progression after first-line hormone and chemotherapy. And the question we're asking is there a pathogenic variant present? Next slide, please. So in this case, the expected result was no pathogenic variant detected in either BRCA1 or BRCA2. Two critical genotyping errors were made, so 2% of the participating laboratories, and both of those were false positive results. So one laboratory correctly reported the presence of a BRCA1 variant, whilst another report incorrectly reported the presence of a different BRCA2 variant. Looking at the interpretation of the case, one critical interpretation error for this case. So the interpretation given was that the patient carries a somatic mutation in BRCA, or one of the BRCA genes, which are members of the HRR gene family, and a particular treatment is being proposed as a choice of treatment in this appropriate clinical context. But clearly this patient doesn't have a BRCA variant, and therefore you wouldn't recommend this type of treatment. 16 laboratories, or just 20% of the laboratories reporting the results for it, failed to provide any interpretation with respect to PARP inhibitors. And all of these laboratories lost marks as a consequence. In the case of prostate cancer, PARP inhibitor therapy can only be prescribed if there's a BRCA1 and BRCA2 variant present. And we really did expect every laboratory to report that on their report. Next slide, please. A further 16 laboratories, or just 20% of the laboratories, failed to provide any interpretation, as we just covered. Some laboratories also failed to indicate or include the neoplastic cell content of the report. Again, this is the same scenario that Sandi reported in this, exactly the same sort of scenario in the ovarian cancer scheme. So if you don't detect any pathogenic variants, it's really essential that you provide an estimation or some sort of comment about the lack of neoplastic cells in the case, because you don't know whether it's due to the fact there's no neoplastic cells present, or the assay performance, etc. So it's really essential that you have some sort of statement on neoplastic cell content in the report. Laboratories were also deducted marks for this case for not providing any limits of detection for the assay performed. Again, you really do need to state how well your assay works in the context of no pathogenic result reported. Next slide, please. So in scoring and the summary, as expected, case 3 had the highest mean genotyping score, but the lowest interpretive score. Clinical accuracy and reporting was very consistent across all cases, and that's the theme that's been reported across all of the 3 schemes this year. So great to see that area, but definitely improvement can be made in the genotype particularly, but also the interpretation. Next slide, please. So looking at the performance trends, well, it's obviously hard to draw a trend across 2 years worth of EQA schemes, but nevertheless, we'll draw some trends. And obviously the same point about participation as we've repeated for the other 2 schemes is relevant here. Only just over 80% of laboratories actually submitted results, and a further nearly 20% of laboratories either withdrew from the scheme, and a smaller number of those actually didn't submit any results either. Looking at the genotyping error rates, again, it's not unexpected and there's no trend here, but we see, as is common with all new EQA schemes, a very high critical error rate, so 8% critical error rate across all 3 cases, and a smaller but notable error rate associated with interpretation of about 1%. And I think the thing to highlight here is the number of poor performing laboratories. So in the germline scheme, it was about 12%, and in the somatic scheme, it was just under 10%. Here in the prostate scheme, nearly 20% of laboratories were poor performers, or a fifth of the laboratories. Most of those made just 1 mistake in 1 case, but there were a couple of laboratories that made 2 mistakes in 2 cases out of the 3. So this is not unusual in terms of new schemes, but it's obviously indicates why the EQA is important moving forward. And regular participation is absolutely essential, I think, to sort of cover your quality perspectives in these types of activities. Next slide, please. So I think it's now over to Sandi for the shared learning.
Lovely, thank you, Simon. So I'm going to do this quite quickly and high level, next slide please, because I'm aware of the time running out. So we've got quite a few positives, I think, looking back over the years of data. We're now seeing a very high degree of compliance with HGVS variant nomenclature, which makes life much easier, particularly now that data is being submitted to multiple databases internationally, and again that standardizes, so we're all sort of speaking the same language, so that's a very great big tick on the box. We're also seeing an improvement in the use of reference sequences. Only specific and appropriate sequences are being referenced on the reports, and again that is really helpful for standardization and knowing which variant we're looking at. Also, we used to have very, very long, complicated multi-page reports, and again a lot of labs have taken time and effort to review comments, feedback comments, and these are becoming much more concise and very easy to find the take-home message and the actual result and the interpretation. So those are really great positives going forward. So next slide please. However, there's still work to do. Variant classification is something that we all have to work at. We have to put a lot of time and effort in, especially with ever-changing guidelines and also new resources coming to hand. So we do still have a lot of labs only using a single source of evidence, and that's ClinVar. Now, whilst ClinVar is a very useful tool and we all do need to use that, there are other multiple resources out there, and it's really about that combination of evidence finding to come up with your actual true variant classification. And a quick plug is that we're holding a webinar on Monday to start looking at variant classifications, the guidelines, how to apply them with some worked examples. So I would definitely register for that if you're interested. We're also still seeing the reporting of presence of non-pathogenic variants, list of benign and likely benign variants interspersed in the report, along with those that are pathogenic, or even in a report where no pathogenic variants been detected. And really this can be quite confusing and easily misinterpreted that there has been a pathogenic finding there. So we strongly recommend that these are not included on the report. They should be held and be able to find easily within the laboratory, but not present on the clinical report. I think through the majority of the errors that we've seen in the interpretation category, it really comes to this third point here, is about answering the clinical question that's asked. Not always do we want to just see the reporting of the result of the test, but we want to put that in the context of the clinical case that the testing is being performed for. Now, we know that some countries and some testing strategies are set up that the laboratories don't actually provide this service, but we do need to have some sort of information there as to what the impact of the result is. And then also, when clinically relevant variants are not found in the germline sample, it's important to recommend testing for somatic variants in the tumour. So this is the flip side that Simon and I have been talking about, whereby if a variant has been found in a somatic setting, then really there's a chance that it could be a germline variant. And this is where a germline variant's not been detected. There's still a possibility there could be a variant present in the tumour sample itself. So next slide, please. And then finally, so we also want to know about as I've mentioned, when a pathogenic variant is detected in the tumour, that there's a really strong recommendation that we say that there should be a referral or some sort of acknowledgement that this could be a germline finding. That also should be extended not only to the individual, but the fact that it may have impact on the wider family if that is the case. There's an increase of labs providing better details and methods, but some are just really not, are very sparse, and it's very difficult to understand what's been tested, and more importantly what's not been tested, and the limitations of the testing being performed. And really that is so when the reader of the report knows the limitations and how far they can interpret the data. A very, very strong recommendation from these EQAs is to include your copy number variation analysis in the germline setting particularly. We know that large genomic rearrangements are around 15% of all inherited BRCA1, BRCA2 cancers. So we would definitely recommend that copy number variant analysis is fully validated, completely verified, and is fit for purpose, and also applied to your clinical testing. Next slide, please. Just to finally close, that the EQAs obviously are ongoing this year for 2022. We have the germline scheme, which again covers ovarian, breast, prostate and pancreatic cancers. We have our ovarian and prostate cancers symptomatic tissue testing EQA, so that's the two thematic schemes we've talked about today will be combined into one EQA. And we also have a prostate cancer EQA, which is plasma based, so this is liquid biopsy testing, and the samples will be shipped out in September. We have a huge number of participants already enrolled, and I think we're pretty much up at our maximum, but if you have not yet enrolled and wish to do so, then please contact either GenQA or EMQN offices, and if we can at all possibly, we will be able to incorporate you into the EQA. So next slide, please. That just leaves me to say a massive thank you, Simon and I. We did intend to do some question and answer sessions, so I'm going to just refer to our organisers to see if that's possible, or shall we do this as a written response?
We're happy to do maybe two questions, Sandi, one each, and then what we will do, as Sandi said, is we'll feed back to you guys. So we've got your questions in the Q&A. We will review those and feed back to you in a written response, which we'll incorporate into the feedback. Just one question here. So we've got a question here that says that this is a laboratory that's just started reporting BRCA1 and 2 BRCA variants, and they wondered why we've not included the variant allele frequencies in our worked examples or in our case reporting for our validated results. Are you missing anything? So let me just hold up our hands and say, you're not missing anything. Don't worry, you've not done anything wrong. It's because we're using germline samples for our materials as our backbone, if you like, for making materials. So everything you will find should really be around about the 50% mark in all the cases. And where they're not, as in case 2 of the prostate, for example, with the large deletion, there's a good reason for that why you might find that at a different variant allele frequency. Sandi, do you want to add anything to that at all?
No, I think that's fair. It's just one of the nuances of an EQA provision. Yeah.
Yep. Do you want to pick up one? Have you got a question there?
A couple here about databases. So again, I would say definitely register for the webinar on Monday. And if you can't, I would attend live, I would register, and then once it goes through approval, they will be available to download from both EMQN and GenQA YouTube channels. So I would definitely recommend that. But there's one here specifically I would like to pick up on, and that is, do you have a recommended tool or database for converting MLPA results into genomic coordinates? As COFALISA does not give the genomic coordinates as an input. So I would say it's very difficult to standardize that. Your genomic coordinates really should be limited to where your probes are located in your MLPA assay, and that will change depending on version number or which kit you're actually using. So you would have to be able to know where your probes were sitting before you could actually report that. So you couldn't report the actual true deletion or duplication extent. You can only report as to where you're able to detect it from, so as in those endpoints of your MLPA probe. So it's not quite as easy as popping it in a tool and it coming out the other end. So sorry, but that's the way it is at the moment. It's why it's challenging.
I think we've probably run out of time, to be quite honest. We'd love to answer a few more, and we will pick up all those additional questions offline for you. So I guess it just remains for me and Sandi to thank you guys for dialing in. We really appreciate you giving up your lunch times, and we hope you found this webinar helpful. We've certainly enjoyed, as we always do, giving the feedback to you guys. So a big thank you to all the laboratories who took part. We hope the scheme's been beneficial from you, and we'll hope to see in your feedback whether that is the case or not. A big thank you to all our experts, our scheme assessors, our volunteers who give their time for free in our assessment process. And finally, a big thank you to my co-host, Sandi, and from myself. And we really look forward to catching up with you this time next year when we report the data back from the 2022 scheme. So thank you very much indeed, and enjoy the rest of your afternoon.
Thank you. Bye-bye.